we try to gear them toward one modality over another. It's really just presenting a person their options and having them, decide from themselves or with their caregivers what the best option is going to be.
Hello, everyone. This is Cole from the American Journal of Healthcare Strategy, joined by a really special guest today. It's actually a follow-up on some of the previous discussions we've had regarding CKD and population health, but we're taking a real clinical deep dive into it today, speaking with an incredible clinician, Dr. Toth. Stephanie Toth, can you please introduce yourself?
Yeah, it's nice to be here. Thank you for the invitation to be here, Cole. So, as Cole said, my name is Stephanie Toth-Manikowski. I'm a nephrologist. I live just outside of Chicago, and we can go into sort of why I pursued nephrology, but I'll give you a quick background. Many, many years ago, I did my undergrad out east at Harvard, and then I came back to my home state of Illinois. I did my medical school education at the University of Illinois in Chicago. It's a public institution. It really sort of helped me realize early on that I really like serving an underserved population. Having finished medical school, I then went out east to Boston Medical Center, which is Boston's health safety net hospital. I did a 3-year residency there in internal medicine, followed by a fourth chief year in internal medicine. And then thereafter, I did my nephrology fellowship at Johns Hopkins. Traditionally, a nephrology fellowship is 2 years. I stayed on an extra year to do a master's of health science where I focused on clinical epidemiology. And the goal there was really to be able to come away from my training with the ability to do sort of analytics on large populations. Ideally with kidney disease, which was obviously my specialty. I came back to Illinois where I practiced in the city of Chicago, again at the University of Illinois, Chicago for a number of years. I trained medical students, residents, fellows. I did a lot with obviously the CKD and ESRD population, did a lot of home dialysis, which is something near and dear to my heart. And then, a few years later, I started to look to see what else was out there. And I was fortunate enough to find Healthmap Solutions. For those that aren't aware, Healthmap Solutions I think of it as a kidney population health management company. So we're fortunate enough to be able to sort of identify people in the population with kidney disease, anywhere from stage 3, which is fairly early, all the way to stage 5, and ESRD as well, and a handful of transplant patients. And we have a team of nurses that sort of works with those patients and also with their healthcare providers to try to improve clinical outcomes and obviously reduce unnecessary spend in the healthcare system as well.
That's great. Super impressive resume and experiences, and also very mission focused, which kind of brings me to the first question that really came up in my mind is, you get into Harvard. Clearly you did great in high school. It's a prestigious organization. It sets a lot of students up for success. And of course you got into med school, which is another accomplishment, and you go down the nephrology path. And, a lot of people might say, nephrology, it's a nice specialty. It's okay paying, but you could have done really anything, right? You have the brain power and the commitment clearly to do pretty much anything you want. Why do nephrology? What really drew you to that?
I mean, it's a great question. So if you ask my parents, I wanted to be a neurosurgeon since the very young age of something like 4 or 5. I had it in my brain that I wanted to be a female surgeon and, practice at the top of medicine. And to me, that was neurosurgery. I was fortunate enough actually to do a quick rotation before I started medical school with a neurosurgeon. And I realized early on that type of medicine was not for me. It was a little too grim, a little too morbid. It's funny that, I ended up choosing nephrology. There's very sick patients with kidney disease as well. But the reason I gravitated toward this patient population was twofold. So one, I really like that nephrologists get to have a longitudinal relationship with their patients. And what I mean by that is, when you're treating patients, oftentimes you start treating them when they're stage 3 CKD, and, unfortunately some will progress. And those that progress to ESRD, I think of it as an opportunity to help them, make that transition as easy as that difficult transition can be, right? So you educate them about their options, you help ease them into the transition. My goal was always to try to get them to home dialysis if it was the right option for them, because, improved quality of life, improved clinical outcomes oftentimes. And the best part was that I could, treat them to whatever through whatever dialysis modality they transitioned to, whether it was in-center hemo, peritoneal dialysis, home hemodialysis. Um, and once they transitioned to ESRD, my main focus was always to try to get them on, evaluated for a kidney transplant. For me, that was the biggest highlight of the month. Whenever one of my patients was transplanted, I'd always make sure to see them in the hospital. Sometime, always hug, maybe some tears, but it's a tremendous sort of barrier to overcome, and it's a huge win. And so for me, it's a really a privilege to be able to take care of a patient for over the course of so many years. And, once they achieve that transplanted status and they're cleared from the transplant team, oftentimes they come and they see you back in your CKD clinic. And so for me, I loved, over all those visits, you get to know a person, you get to know their family, you get to know their likes, their dislikes. And for me, it that was the fun in nephrology. So that's why neurosurgery didn't work out for me, but I think for all the right reasons.
I'm hoping a lot of the nephrologists listening in might resonate with this, of course, and of course the administrators listening in. I hope they can sense your real passion and maybe concern. You seem to have a lot of concern for the people in that population. What are the biggest challenges you have faced as a nephrologist with that population, working with them? What's been the biggest roadblocks to getting them care?
I think it's a diagnosis that nobody would wish upon their worst enemy sometimes, right? Not to make it too dramatic or awful. Like it's definitely a disease that can be managed, but what I'm referring to is sort of that advanced stage CKD, especially, because CKD is a diagnosis or a disease state that really doesn't have any symptoms until really you've lost maybe 85, 90% of your kidney function. I think I saw way too many times that people came to me in those late stages. And it's a tricky conversation to have. If you're meeting a person for the first time and you're talking to them, maybe they only have 18% kidney function. And then all of a sudden you have to start talking about what happens when the kidneys fail. It's a lot of heavy topics to start out with. And so obviously and I think most nephrologists would want to see those patients earlier, sooner rather than later. Um, but the biggest challenges I think are because it's such a difficult diagnosis to be dealt. I think there's a lot of denial, right? And so I think a part of that lends to people perhaps not following up, right? And I can only help the person that's sitting in front of me as a nephrologist, and so it's hard, I think, to see patients falling through the cracks, and what happens because when you're not in the clinic, you're in the hospital as a nephrologist. And so when you're in the hospital as a nephrologist, oftentimes you're seeing patients in the emergency department that are being told for the first time that they need to start dialysis forever. And obviously that's not an easy thing to do. Nephrologists do it all the time, but we don't like that situation. It's far better when you can be seeing that person in clinic and developing a relationship with them over time. But I think that for me is not so much a challenge, but something that happens in nephrology that I wish didn't happen.
And so the reason I asked that question, and I love your answer, it's a very powerful answer, but is why, with your qualifications and your experience you'd been through, it makes sense why you're in nephrology, but how does Healthmap Solutions fit into your plan here? Because you really do seem to have that passion to want to remove this struggle or make it at least more manageable for them. How does Healthmap Solutions actually do that for you?
Yeah, it's a great question, Cole. I mean, I think we target that specific problem a number of ways. I alluded to the fact that so many people fall through the cracks. CKD is an asymptomatic disease. They don't know they have it. I think one of the things that, one of many things that we do is, we try to work with patients early on in their CKD stage. So as early as stage 3. To me, if the earlier you can find a person in their CKD stage process, the more you can keep them in those earlier stages, the better that person's life is going to be, right? So that's one. And we can sort of go into more details, but, another one that I think addresses the problem I highlighted is that way too many people are falling through the cracks. And I think part of the reason for that is, the way the healthcare system is set up is, as a physician, I can only help the person that's sitting in front of me, right? But what about all the people that, miss their appointments for whatever reason or forgot they had an appointment, right? And, maybe my clinic doesn't do a great job of making sure those people are brought back in, right? Then those people could go many, many months or potentially years without seeing a nephrologist when they should have. And they may not know it. because they're feeling okay, right? And so what Healthmap does is, with the way our model works is we can identify who those people are, right? Who are people with advanced CKD that haven't seen their nephrologist for 6 months, 9 months. We've got a lot of people that we see that haven't seen a nephrologist in over a year, when they have stage 4, stage 5 kidney disease, which is very advanced kidney disease, right? So I think that's one of the biggest impacts that we bring to this population and to the healthcare system.
One of the things though about that is, we talk about how vulnerable this population is, and you can look at the SDOH measures. One of the biggest things is it's usually not, they're not avoiding the nephrologist because they, don't like, I mean, sometimes it's because they don't like doctors, right? But a lot of times it's another barrier, transportation, safety, finances. What about health maps helps people to overcome some of that and get them the services they need? Whereas if you're a doctor, you're kind of like figuring this out on your own, right? You're kind of like put out there to figure it out.
Absolutely. Yeah, I mean, what I think works really nicely about our model is that we have a nurse who will outreach to our we call them members because we don't render care, so but they're somebody's patients, right? They're people, and so our nurses will work with these members, and they do a number of assessments. To your point, some of them are assessments for social barriers to care. Sometimes they're assessments for behavioral health barriers, right? And so whenever we identify a barrier, regardless of what it is, we can then loop in one of our multidisciplinary care team members. So we've got social workers employed by Healthmap, we've got registered dietitians, we've got pharmacists, right? And I can give you success stories for every single one of those multidisciplinary care team members, right? To your point, transportation is a barrier for so many people in this country. Our social workers do a phenomenal job of, figuring out, do you have transportation benefits through your health plan? Do you have transportation benefits because of a diagnosis that you have, or in the community that is a resource to you that you're just not aware of? We've had our social workers help house people, which I've always thought is just incredible, right? Imagine, being without a home, and obviously your number one priority for the day is going to be to figure out where to find some temporary roof, as opposed to, how do I get to the doctor? So, social workers in our team, I think, move mountains. Our pharmacists, I can't tell you how. So let's start one step behind. So there was an article published now a number of years ago, but it showed that the average number of medications that a patient with CKD, unique medications that a person with CKD is on, is something around 12 unique medications a
Wow.
day, right? Like I can't even take a vitamin every day, let alone, can you imagine taking 12 different medications? And sometimes they have to be taken twice a day, 3 times a day, right? And there's a cost to all of that. And it's a very real financial consideration that sometimes people just can't meet. And so our pharmacist, I work with her very closely. She does a tremendous job of making sure that, if there is a way that we can help get people their medications at a reduced cost, that we do so. And then certainly, last but not least, our registered dietitians. I think the way I think of dietary modification is, it took me many, many years of schooling to understand what the heck a person with kidney disease should eat, ideally, right? You got to watch your salt, you got to watch your potassium, sometimes your phosphorus, right? Like, I know what that means because that's my job. But if you're new to all this, it's really hard to understand what you should eat, more of what you should eat less of. Now you throw diabetes into the mix, it becomes really challenging to figure out what to feed yourself. But what if you got kids in the home, or you got to feed a spouse or an elderly person that you're right? So like it's very tricky to do that. And what I love about our registered dietitians, and all registered dietitians, right, is they can really walk a person through that and help them understand, what changes to make so that they can better their lifestyle. And I'm going to put a shameless plug in for our RDs. Um, I'm I'm hesitating because of the number of success stories I'm trying to communicate, right? But I mean, they help our patients meal plan. They've helped them lose enough weight that they're coming off some of their blood pressure medications, right? They've helped patients who were too obese to be listed for transplant be listed for transplant, right? So, like, truly changing people's lives. Um, and I just love that they help our members sort of get there.
Yeah, that is so vital. I mean, I think there was a statistic very recently, or an estimate, that 30% of people who are on dialysis started dialysis as a crash start to dialysis, right? So when you're talking about managing at stage 3 with nutritional resources, so they're not going to get to that point where they have to take, hopefully, all of this equipment and have to, or do as much. Can you explain, though, in more detail for those like myself who aren't as familiar? Why do we want to prevent that crash start? And what I really mean by that is, what are the stages in between, right? What's the difference? What are the difference in outcomes between someone who crashes to dialysis and then we manage with health maps, and then someone who never had that happen, who's able to go, have some of the earlier stages managed?
Sure. And I might ask you to repeat the question once I get going on a track and I forget what the original question was, right? But the way I think of it is, if you can catch someone early in CKD and sort of keep them on that trajectory, everybody's going to lose a little kidney function every year. It's part of getting older, right? But the goal is really to slow that drop in kidney function year over year. The benefit of doing that, right, is the earlier or the better your kidney function is, the lower your likelihood is going to be of having a heart attack, of having a stroke, right? And anybody who's sort of taking care of a person that's had a heart attack or a stroke, this is sometimes it's a catastrophic health event that really changes the course of that person's sort of quality of life thereafter. There's a number of meds that people have to take after a heart attack or stroke, right? And of course, there's that cost to the healthcare system as well, right? Which I think clinicians think less of, but it's there whether we like it or not, right? So keeping a person certainly away from dialysis, but just healthier in an earlier stage of kidney function,
Right.
and really that's just better kidney function, they're going to lead a healthier life. So that's like, I don't mean to oversimplify it, but it's really
No.
just a healthier life.
And that's because of the food and the farm being able to take the right medications. And that's all of those services that enable that.
So it's all, yes, big picture, it's lifestyle modification, right? So eating healthy or trying to lose a little weight if a person's overweight or obese, changing one's diet, getting more physically active, exercising on a more regular basis, right? If you're drinking or smoking, trying to, stop smoking, all these things. But then there's, of course, also medications, right? So there are medications out there that we know slow progression of kidney disease. And it's usually a secondary benefit of the medication. So what I mean by that is, ACEs and ARBs are blood pressure medications that have been around for decades now. They're great at lowering a person's blood pressure, but they have a beautiful secondary benefit of slowing progression of kidney disease, and also they protect a person's heart, right? So that's just one example of a medication class that helps slow CKD progression. So one of the things Healthmap does is we make sure that as many of our patients that could or should be on this medication class are on it, right? Because it's cheap, it's effective, and it helps the kidneys and the heart. Right. And then there's, of course, a number of medications out there that can also harm the kidneys, or they're nephrotoxic, or they accelerate kidney disease progression, right? And oftentimes these meds are available over the counter. If you've taken ibuprofen, Advil, Aleve, right? These are medications that, if taken excessively, can harm the kidneys over time, right? A lot of people have no idea. And so, a lot of what our nurses do when they outreach to members is they educate them about this. Because once then, you don't inadvertently
Mhm.
potentially harm yourself or your kidneys. So that goes back to your question of, what's the benefit of staying in a healthier kidney disease condition, and what's the benefit of avoiding that crash or that unplanned dialysis start? I mean, I think if you talk to anybody who's encountered a person, whether from the caregiver side, the patient themselves, or someone in the healthcare system that's seen a person have to transition to dialysis in an emergent fashion, it's not something, you know, having seen it, you're going to try and avoid it as best as possible, kind of thing, right? Um, there's, and also if you think about it from the patient's perspective, right? All of a sudden you're being thrown into a hospital setting, things are being done to your body. There's very little, oftentimes, understanding of what's happening. You just know it has to happen so that you can get better, be healthier. And then, eventually you're discharged from the hospital and show up in a dialysis facility and they say, we got to do this 3 times a week, right?
Mm.
You can imagine, it's such a shock to one's day-to-day schedule. There's a lot of depression associated with that transition. There's a lot of medical events that can happen around it. And unfortunately, there's a lot of mortality, right? So a lot of people, not because, they're doing anything wrong or the healthcare system's doing wrong, it's just a true shock to the body. And a lot of people, the 90-day mortality after starting dialysis in an unplanned fashion it can be quite high. So for so many reasons, right, Healthmap focuses on reducing that unplanned dialysis start.
Yeah, that's so. And I'll get on a soapbox for a minute and say that it's so key what you're saying. The other medical interventions or situations that happen whenever somebody interacts with the health system, especially if it's a totally integrated network where they're the payer and the provider, you really don't want your members ever having to go into the hospital because
Right.
it opens Pandora's box. And if you're employing total quality management, you want to look at the person holistically, which I love that this is what it's doing. I mean, that's really what we're doing. What does that look like though in the physician's end? So because you practiced, of course, what it's you have both sides. So as a physician, what are you seeing when health maps, patients, were to come to the clinic or something like that? What would that look like
Yeah,
hypothetically?
absolutely. I mean, I find that my patients are better educated about home dialysis options. And so I'll get on my soapbox, right? One of the things that I learned when I was still training is that 95+% of nephrologists would choose a home dialysis option for themselves or their family members, right? And yet, close to 80% of the people on dialysis in this country are being dialyzed in a center,
Mm.
right? Like, think about how different those numbers are. And so, one of the other things I learned is that if you look at the people that are being dialyzed in a hemodialysis center, right? Close to two-thirds have never learned or heard that they could be doing dialysis in the home, right? And then again, if you look at other studies, if you educate a person, a lay person, myself, anybody who's never heard about dialysis before, and you present them their options about, you could do dialysis in the home, here are the pros and cons, you could do dialysis in a center, here are the pros and cons, you talk about their life and, what would the best option be for that person, more often than not, a person is going to choose a dialysis option in the home. Right.
Wow.
So for me, one of the really important things that our nursing team does is they talk to our members about their options when and if they should progress to kidney failure. Right. And so now you have a person who's been educated about the options. And it's not so much that we try to gear them toward one modality over another. It's really just presenting a person their options and having them, decide from themselves or with their caregivers what the best option is going to be if they should progress to ESRD, right? And then to answer your question, what does Healthmap do? It's that communication and that care coordination with the nephrologist. We had a conversation with your patient. This is what we discussed. And then sort of the nephrologist can take it from there. And then when the nephrologist sort of works with the patient to decide what the dialysis plan is going to be, we can then help care coordinate on the other side, right? Let's make sure we get your vascular access appointments going, or let's make sure we've got an appointment with the surgeon, and then once the procedures have taken place, we can sort of coordinate and educate around how best to manage stitches and what's the next steps, right? Because all of this is new to a
Yeah.
person, right? And so I really appreciate that they sort of take that on themselves and make sure that the person has as easy of an experience as possible going through a pretty hard.
Yeah. So if a clinic was staffed with, or it only had patients that were coming from HealthMap, it must be a lot easier to maintain. If like let's say that was a hypothetical, right? It was
Sure.
only HealthMap patients. I'm not sure if that's happening, but in the future, from what I understand, that will be happening
That'll be
after
great.
talking to Tom. The thing I'm wondering is it easier to maintain your quality metrics as a physician? Do you not have to worry as much about that continuity of care when HealthMap is doing that communication?
I think anytime, yes. I think anytime you have somebody helping to coordinate care outside of your four walls, right, or be the eyes and ears outside of your clinic, um, that's, I think, what we're all striving for. And I do think that that's what Health Map helps provide, right? It's those eyes and ears outside of the clinic. What's going on with my patient? Oh, you talked to him or her about this. Thank you. Right? These are the
Yeah.
next steps. Can you start that conversation for me?
And so if it wasn't for that, who would be doing that? Nobody? Or medical assistants, or like who's there to do it if Health Maps isn't doing it?
It's a great question. I'm hesitating because I want to say, in an ideal setting, in a clinically integrated network, there's going to be a care navigator doing that. But I'm trying to think back, and I've never worked in a healthcare system that has been able to provide that type of care coordination that Healthmap is providing. And I'm not trying to sound too one-sided.
Oh, right,
I
right.
think what we do is really great. Nothing is perfect, right? But I've never worked in a healthcare system where we've had the type of care coordination that HealthMap can provide to a clinic that's working with us.
Yeah. And I think that's important because payers sometimes there's an idea that, the quality outside of what's happening doesn't always impact us directly. It impacts us down the road as a payer, and so sometimes we can let quality slide initially because we don't know that down the road it's not going to be coming back to bite the physician. A lot of times it's going to be coming back to bite the patient and
Yeah.
the payer, financially speaking. So I think that's really important. It's really important. Physicians are maxed out. They don't have the time to do it. There's not really a lot of robust infrastructure. And then Health Maps just comes in and is able to do it. And from, talking with Tom and Eric, it's affordable. And to know that they have individuals like yourself who are working on this is really incredible. And I appreciate you coming on and talking. I'm going to leave you with a final kind of send off question. And it's, what do you think the future is holding for kidney care and for nephrology as a practice? What do you think is going to be happening in the next 5 years?
Yeah, I think it's a great question. I mean, so I was speaking with a nephrologist recently, and she thought that we're at a point where, maybe we don't have to worry about dialysis anymore. And that caught me by surprise. And I think I've thought about it from time to time since our conversation. I think we're not quite there, meaning I think unfortunately too many people are still falling through the cracks. They're not getting, they're again, going back to the idea that CKD is asymptomatic, people progress, and they just don't know. And anyway, but I do think we're in an era where we have so many therapeutics for people with kidney disease, beyond ACEs and ARBs, that we'll be able to start them sooner and keep, slow that progression of CKD early on. And I think from a clinician standpoint, but also from a patient standpoint, I think that's like there's been so many breakthroughs when it comes to medications that slow kidney disease. So
Hmm.
I think the more patients we can get on them, hopefully the less planned dialysis starts we'll need, right? Because
Yeah.
people hopefully we'll see fewer people progressing to dialysis in the future.
So we can't give up, hang up our hat, but we do have enough motivation to keep working, is what you're saying. Like we can't,
Absolutely.
it's
You
not
said it
time to let
far
off the
better than
gas.
I did. Yes.
Okay. But we can see those things on the horizon. So I appreciate that. That's a great, I think it's a great place to conclude. It's tough right now, AI and things, people are all anxious about it. And I think that's a good place to conclude. So thank you again, Dr. Toth, for coming on. We really do appreciate it.
No, I appreciate the invitation, Cole. It's my pleasure. Thank you.